Everybody, welcome to Alabama EMS Challenge. We're at Mountain Brook Fire Department today. If you're in the area, please come by and join us. We'll have lectures between now and 11. Then we'll have lunch and a skills lab. And we're going to go ahead and get started with Dr. O'Brien. So take it away, Doc.
All right. Hey, everyone. I hope you can hear me. I'm Callie O'Brien. I'm one of the second-year emergency medicine residents at UAB. I have already got wonderful things to say about Mountain Brook Fire Department. I told a trauma surgeon I was headed here to do a lecture, and she said, tell all of them thank you. They helped her husband put the car seat in when she had her first baby. And she said, that is the most lovely fire department they have ever interacted with. So rave reviews from the trauma surgeons at UAB. I am going to be lecturing about seizures. I was so excited to get the logo, and then I heard that y'all don't even use this one anymore, so please forgive that. I have no financial disclosures, but Dr. Ferguson did give me this polo, so I don't know if that counts. I've got some learning objectives here. We'll be able to identify different presentations of seizures, discuss different causes of seizures, and be able to identify the seizure treatment algorithm and key areas where we deviate. So the best way this presentation is going to go, if we have a lot of participation, I've got a lot of fun cases for us. All of these are real cases that I've been a part of through the last 2 years in residency. But if you don't feel like participating, or if you're online, don't worry about it. I married an extremely quiet man, and so I am used to talking for both parties all the time. So we'll go right ahead into our first case. And hello to I've made a bunch of friends this month. Everybody online, I know you're there. I know you promised you'd be there today. So case one. So we're going to present, I'm going to present a couple bullet points, and then I'm going to kind of open it for discussion and see what y'all want to do. You get a call. You have a 6-year-old girl. She's got history of seizures, and she's currently seizing. Over the phone, mom says that she's got some jerking movements in all of her extremities, and now she's sitting with her head turned to the right and her eyes looking to the right, like that, for those who are in person. She does have a rescue agent. That's the intranasal diazepam or Valtoco. And she hasn't given anything yet because she's nervous and wanted to wait for EMS to get there. So what are some things that you might want to do just hearing this information? Yes. Wow, that was so fast. You got that great. So yes, maintaining a patent airway, making sure that she's protecting her airway, and a big one, checking a blood sugar. I think all the ABCs are important, but especially in seizure, the airway is so big. And then are there any questions history-wise or anything on the physical exam that you might want to ask mom or that you're thinking about getting that information? Yeah. Yeah, those are great questions. Yes, those are great questions. Oh, I was like, oh my gosh, who is that loud woman? It's me. So you guys are asking all the right questions that you should be asking in the field. You asked about her recent seizure history. Mom tells you that she hasn't had a seizure in months, but she says that these seizures do look like her daughter's normal seizures with the tonic-clonic jerking. And then she says that her head doesn't turn to the side and her eyes deviated. That's pretty typical for her seizures. This still looks like she's having a seizure. You mentioned recent illnesses. Is she having fevers? Has she been sick recently? Throwing up? Is she not able to tolerate her seizure medications? And then, like we already said, making sure that this isn't a change in her seizure morphology. So you guys already hit everything. We talked about the ABCs. We talked about checking a blood sugar. Would you guys recommend, with her saying she's not jerking, she's not having tonic-clonic jerking anymore, but she does have her head deviated and her eyes deviated, would you recommend giving the rescue agent if she was asking you? I see a lot of head nods. I like that. I love that we're nodding our head there. And just for you guys to know, she had a normal temperature. She's not been sick recently. She's not been throwing anything up. No history of trauma. Great job for whoever asked that. So that's really awesome. This patient, just for reference, was a child that I took care of when I was in the PICU. I was in the PICU last month, and they were transferred from a pretty rural area, kind of outside of probably where the people that we're talking to today. But this is what ended up happening. I do think it's a moment for education for this crew, but they brought the patient to Children's ED. They decided against the rescue agent. The big quote that the mom had was that someone along the way said, well, if it's not a grand mal, I don't think we need to give the rescue agent. And that's a big misconception. They thought that just because she wasn't having the tonic-clonic jerking, she wasn't seizing anymore. A blood sugar was not checked, so excellent job for saying blood sugar real quick. And they didn't check an O2 sat until we got to the ED. So I mentioned on the first slide, like ABCs and vitals and like physical exam. They noticed the motion she was doing on physical exam. Because she was seizing, and I was talking to some doctors in the PICU, they're like, especially children having seizures, it can be really difficult to obtain an O2 sat. And so they were like, oh, it's probably just our probe, and they kind of waved it off. So this was kind of her course at the hospital. So at that point, by the time she got to Children's ED, she was seizing for 2 hours. Her O2 sat was in the low 80s when they got there. They put her on oxygen. They gave her Versed. They gave her a Keppra load, and then she was intubated. She had a pretty short course in the PICU. We extubated her a couple hours later. She returned to baseline. Neurology came and increased her medications, and then she was discharged. She had no poor outcomes long term. Does anyone know why she seized? Any ideas? Yeah, so that's actually, it's really close to that. This is such a common thing in peds populations. They won't seize for so long, and then they'll go through a big growth spurt, and they outgrow their the dose of Keppra, or she's on trileptal, which is oxcarbazepine. So she just outgrew her dose. So this is, I was talking to the child neurologist about this. They were like, it's actually really common for, they try and stay ahead of it, like by monitoring their growth and everything, but something that you can bring up to moms and parents in the field if they're like, why is this happening? We haven't missed any doses. Sometimes it's not about missing doses or that they've been sick recently or having trauma or anything like that. It's because they are just outgrowing their medication and need a higher dose. This is just something I thought was really interesting that the child neurologist shared with me. It's probably not that helpful, but they mentioned that like when a seizure, because the seizure changed, and that was a big kind of point for the medics who first saw them about saying no to the Valtoco, was that the seizure changed. They were like, oh, it went from generalized, where she was having this tonic-clonic jerking, to something more focal, where her head was turned to the side and her eyes were deviated. They were saying like, oh, isn't the seizure improving because the morphology is changing? And the child neurologists were saying how that's a common misconception, and that it's actually the electrical conduct. A seizure is electrical misconduction, and when it's changing from generalized to focal, it's specifically crossing physically in the brain where the activity is occurring. So typically they were saying that when it's going from generalized to focal, it's crossing hemispheres. So the activity is still just as strong, it's just changing places where it's at. So I thought that was really interesting. I had no idea before learning that. I wanted to touch on, so this is what this crew did. What does the great state of Alabama say? I love the key that they have for us about what everybody can do. And so everybody can check a blood sugar. Kind of a big important point for us to remember. They talked about considering IV access, and then we get into the medications we can give, like the lorazepam or Ativan 1 to 2 mg IV, which is the 0.1 mg per kg IV with a max of 2 grams, and then or the Versed, which we have listed up there, the 2 mgs IV/IM or 10 milligrams intranasal. These are adult dosing that we have up here, but I think that the big thing in this case was encouraging the mom to use the rescue agent. I love the note that they put on the side of this of the thinking about the symptoms related to a specific cause of the seizures or etiology of the seizures, which we will get into in the rest of our lecture, not to give anything away. And then they're just listing other options. And then it's always stopping the seizure activity with a benzodiazepine and then considering a Keppra load if within your scope. All right. Next slide is funny to me. See your misconceptions. So I don't know if you guys have looked at the 11th edition of Alabama EMS protocol. I definitely did when I was preparing this lecture. But they have a whole separate bullet about not putting anything into the mouth of somebody who's seizing. I didn't know that that was such a common misconception or that we needed to say that. But if everybody can remember in the office when Michael was shoving his wallet into Stanley's mouth, don't do it. I just wanted to bring it up since they thought it was so important to put it in there. I agree, it's important. I also put this is a clip from TikTok. I know nobody's on TikTok. We're all above that. But there's this whole category now, if you're like me on Instagram Reels or TikTok, about chronic disease influencers and like PNES influencers. I think it's one of the craziest phenomenon that I've ever seen. This is just kind of a funny little seizure misconception for me. I love saying everything is PNES, so not everything is PNES. I did recently have a patient in the ED who he was saying that he had the seizure-like activity, and then he would record himself before he went into the seizure activity, and then he would, while he was having the seizure, would stop the recording, and then he'd wake up. And so while we can't say everything's PNES, I feel like it's pretty safe to say that one is PNES. But we'll get right into the types of seizures. So there's two main categories of seizures and then subtypes in that. We have generalized seizures, which include absence, tonic-clonic, which is like the traditional like grand mal, and then atonic seizures. Atonic seizures are a lot more common in like genetic disorders with kids, like Lennox-Gastaut syndrome. They're also a lot less common than tonic-clonic seizures, which you guys have probably all seen. There's also focal seizures, and then a big branch point is focal with preserved and impaired consciousness. So it's in the name itself. If they're still talking to you and answering questions and understand where they're at, that's going to be preserved consciousness. And if they don't, or if they're unresponsive, if they're not talking to you, it would be impaired consciousness. In our case, our little girl had a generalized seizure that changed to a focal seizure with impaired consciousness. I wanted to bring this up because focal seizures can really be, this is the importance of a really good physical exam. They can look a lot of different ways. They can look like a repetitive movement. They can look like eye deviation or a fixed beating gaze. It's just something important to think about. I also think in the pediatric population, probably a little bit less concerning, but when you see that fixed gaze and that eye deviation, what's a big thing that you're thinking about if you're looking at an adult instead of a seizure? Stroke, absolutely. And so I think that's a key point. Of course, you can have like Todd's paralysis after a seizure where they have hemiplegia or a neurologic deficit after seizure activity. But if you do see fixed and deviated gaze, don't just think, oh, it's a focal seizure. Still do all the stroke stuff in the appropriate clinical setting. All right. So I wanted to go into causes of seizures. So like I said before, a seizure at its base is abnormal electrical activity in the brain that's disrupting nerve conduction. So many states can cause this. Infectious. Who's got an example of an infectious thing that can cause a seizure? Shout it out or don't. Meningitis, that was amazing. An empyema can cause stroke, a big old brain abscess, encephalitis, all of those can cause seizures. Again, while I was in the PICU, we had a guy with the worst sinus disease I've ever seen in my life, and he had a horrible big empyema, and he would not stop seizing until neurosurgery came in and took that goober out. So, and which I had never even thought of as like, oh my goodness, you know, like he's so sick. We were so focused on getting him to neurosurgery and getting that taken care of, but he was really going through it. Another cause is structural with trauma, which you guys see a ton of. Hypoxia, those are typically in stroke and cardiac arrest. Metabolic, with hypoglycemia and hypernatremia, also in liver and kidney failure. Typically, a lot of those patients will be encephalopathic at the same time, so it's just something to think of when you get that call for altered mental status, and then they start seizing. Temperature, somebody mentioned earlier, the little girl having fevers. Has she had fevers recently or been sick recently? And temperature itself can cause seizure activity. I put chemical as kind of a really broad category because you definitely can be seizing from withdrawal, like alcohol withdrawal or benzodiazepine withdrawal. And then you can also be seizing because of too much with substance use and overdose. I did put substance use like a lot of our recreational drugs that I'm sure y'all have no experience with seeing people that are using recreational drugs, right? Of course not. I lump those in the same category as overdose, which I think is those probably should be more of a distinction, because when I put overdose here, I mainly mean things like tricyclic antidepressants or bupropion, or a lot of our antidepressant medications, or when people are attempting to kill themselves, even if it's not with a recreational drug. You can have a lot of seizure activity there, and the treatment varies a lot, and there's some key things that we can do to distinguish the difference. Genetic, like I mentioned, Lennox-Gastaut syndrome with atonic seizures, and then some forms of epilepsy are genetic, but not all of them. And then neurodegenerative disorders. And then I put preeclampsia in its own category, even though you could technically put it in metabolic, but it's so weird and different, it just needs to be in its own category. So what are common seizure triggers for people who we know they have seizures, like our little girl? They have this history. They are on seizure medications. Even though they're on seizure medications, they can still trigger. So I put strobe lights are what I was trying to emulate here with our first image. And then we already mentioned medication. Number one reason for adult patients to have seizures when they have a history of seizures or kind of a relapse in their seizures is medication non-adherence. And then hyperventilation is actually a really common trigger for seizures, especially in pediatric populations. And then I wanted to put in kind of a separate thing about illness. So somebody might say, oh, I'm super adherent to all my medicines. I take everything every day. But if they've been vomiting and not able to keep anything down, then they're not actually being adherent, even though they're trying their best to. And then I put on our little growth spurt here because I think that it's such a key, important thing to remember for our pediatric populations. I also put a little picture of tirzepatide, which is the generic for Mounjaro. The GLP-1s are like super popular right now in this day and age and on the internet and in media, and we're going to encounter a higher percentage of the population who are taking them. There is now, this is the caveat here. This is all based on some anecdotal evidence from some neurologists that I was talking with. I tried to find studies to support this, and it's so new that there's really nothing out there about it yet, but who knows? And they were saying that some of their patients who have epilepsy and are on multiple seizure medications, when they started GLP-1, they began having recurrent seizures because of the decreased gastric motility. It was affecting their absorption. And I thought that was really interesting. I wasn't thinking about that. It might not be the first thing that comes to your mind. So again, it's kind of back to that point of like really good history, really good physical exam. If they just started taking, they probably aren't inclined to mention that they just started taking Wegovy to you, but it could be a key in figuring out why they're seizing. All right. Second case, so very different scenario. We have a patient, he's a 32-year-old man, brought in for an MVC. He had a seizure either before or after the accident. He doesn't really know. Y'all are there at the scene, and he's really not able to tell you. But he's fully back to his baseline. He's hemodynamically stable. He's resting on the wall at UAB. I know so many of y'all have been there. And he's asking for a turkey sandwich. He was not trauma alerted because he had no obvious injury, and he was ambulatory on the scene, and his car really did not look that bad. He does have a history of seizures, and he is poorly compliant with medications. I was his ED physician in this case. I ordered some trauma scans, and I moved on because I was like, you are doing great. You're eating a sandwich or asking to. What are some things that y'all think of with this case, or think that pieces of information you wish you had? I heard his history of seizures. Sorry, I saw you raise your hand. Yes, that's awesome. And that teasing out what medicine he's on is super helpful, especially when we're trying to decide if we want to load a patient. We have a couple different options. It's not always a Keppra load, and a lot of times if they're already on a medication, we like to choose the medicine they're on. So that's super helpful. And then, like we said, the D-stick and the EKG, awesome. I love hearing that. And then someone else mentioned seizure history. I think in this case, it was probably impossible to know about what the seizure looked like or things like that since he was alone in the car. But something to think about if there's another passenger in the car or anything like that. I am 100% convinced that the crew that took care of him did all of those things. We were so busy that he had already offloaded, and I didn't get a chance to talk with him that night. But if I had, maybe some things would have gone differently. So he started seizing on the wall. We gave him 4 of IM Versed because he didn't have an IV, and his seizure activity stopped. But he was totally altered after that, and we were like, is he just post-ictal? What's going on? But because of his recent traumatic history, we know he's been in an MVC, we called the CT scanners, and we were like, okay, he needs to be next. And it's spoiled, but this is what his scan looked like. So as you can see, he's got a big old epidural hematoma. We are unsure in hindsight if he ever seized at all or if he was just losing consciousness, and he knows he has a history of seizures, and so he said, I must have seized, you know? And so now it's kind of this situation of like chicken or the egg. Did he seize at the scene, which would have been an indication for a trauma upgrade or a trauma alert or taking it more seriously? Or did he lose consciousness? Instead of, I think that we the providers in the ED and the crew that took care of him were really reassured by the fact that he had a history of seizures and he was poorly compliant with his medications. But that had nothing to do with his current picture. So after we saw this, he was persistently altered. We intubated him, not on the wall. We did take him back to the trauma bay for that. And he was immediately trauma upgraded, got full pan scans, and he went for a decompressive cranie later that night with neurosurgery because he had impending herniation. And I will say that the time that this happened of him getting dropped off on the wall and seizing and like having impending herniation was about 20 minutes from the time he got there and I saw him to like being completely unresponsive and it being such an emergency. I don't know if any of y'all have worked with Justine McGibney at UAB ED or interacted with her at all. She is absolutely fantastic. She's also the calmest person I've ever met in my life, and she gave me the sweetest call because I was talking to some other patient, and she was like, "Hi, Callie, your patient has decompensated. Meet me in the trauma bay." It was the sweetest little call. We went back, we intubated him. He had a huge tongue, but we got him taken care of. But just a big point, though, I think that it's so easy, especially in the field that we're in, and I'm guilty of it all the time, and we're so used to like Occam's razor of like the most common and simplest solution is always that solution with a history of medication noncompliance and seizures, and he's saying he feels like he had a seizure. All of those are so reassuring against something like this. But if he had not been a patient that we knew that history on, maybe he would have gotten scanned more quickly. Maybe we could have done everything a little bit faster. But hindsight's 20/20. So I have pivoting a little bit. When the cause changes management. each of these points is kind of a different thing that I wanted to key on a little bit. Always ABCs. Someone mentioned at the beginning, the first thing they were going to do was making sure the patient had a patent airway, and that's great. When I say managing airway is big, it's big all the time, but I specifically wanted to kind of key in for traumas and arrests and stroke. Those are all things that the interventions that are going to be, other than like getting ROSC, life-saving or life-sustaining or really change the game, are going to need to happen in a facility with more resources. And that's going to be the biggest thing that y'all can do in the field, is managing their airway. So even if you can't intubate, placing an LMA, continuing to bag, all those things are really important and are not unreasonable at all. Someone mentioned an EKG earlier. That's awesome. It's a really, really helpful tool in overdose and toxicologically related seizures. Does anybody know anything they can see on the EKG in a tricyclic overdose? It's okay if you don't, because I'll tell you. Do we have our docs here? No. Yeah, that's awesome. Yeah. So the wide QRS complex and then prolonged QTC. You'll also see the prolonged QTC in serotonergic agents when they're dealing with like serotonin syndrome. And you can also see Torsades morphology in a tricyclic overdose. You would still give MAG though, as you would with regular Torsades morphology with the 2 grams IV push. Blood sugar. We mentioned that. I'm so glad. Y'all are so good. Everybody has said checking a blood sugar, checking a blood sugar, checking a blood sugar. It's an easy treatment with D50 or D10. And then I have this kind of separate note on preeclampsia, because that management is pretty different than the seizure management that we mentioned earlier. Now, technically, once they're actually seizing, that is eclampsia, but I kind of put preeclampsia as this big umbrella that you might be seeing before they actually start seizing. I do, how many, oops, skipped everything. How many people know Chris White in here? Probably everybody, right? He's really involved with EMS, and he's great. And I just saw him this morning as I was handing off. When I was an intern, we had a patient come in. She had kidney stones. She was super hypertensive. She's like, my back is killing me. I know it's a kidney stone. I have kidney stones all the time. This is when I was an intern. So I was a little bit more nervous than I am now. And I went in, and she was a bigger gal, and she was wearing a big baggy sweatshirt. And as soon as she lifted her sweatshirt, I was like, whoa, you're 9 months pregnant. And she's like, there's no way I'm pregnant. That's not possible. Haha, funny. And I popped my head out, and I was like, hey, Chris White, can you come here with the ultrasound? And so I was put on a sterile glove to do pelvic, and he had the ultrasound, and he plopped it down. And of course, there was a baby head down, and she was delivering. She was not having kidney stones. She was delivering a baby. And as he had his ultrasound probe down, I had my hand in her vagina trying to see how dilated she was. And he looks at me and he's like, so, like, how far is she? And I remember the sinking feeling. I was like, it's just a head. Like, I was so glad he was there with me for that one. And she did deliver about 5 minutes later. But OB got there in time, which was good because she was very hypertensive and very preeclamptic. But you can ask him about that next time you see him. He was quite put out. So there you go. But preeclampsia, though, big key points here. I think all of you guys have probably heard of preeclampsia or know a little bit about preeclampsia. It can occur up to 6 weeks postpartum. So don't forget about it just because we don't see a big pregnant belly. It usually occurs after the 20th week of gestation. So if you see kind of a small bump, it can still be on the differential. A big thing too, again, this kind of just goes back to the really good history and the really good physical. I would not believe how many times people would not mention something like, I just had a baby as a big life event when I'm asking about medical history. The things that you're going to see in the field, though, to diagnose preeclampsia are going to be pregnancy or postpartum, edema, usually bilateral lower extremity edema, and then hypertension. And then the management, if they're actually seizing with actually in eclampsia, is it's 4 grams of mag sulfate over 20 minutes, and then that's going to be followed by a drip at 2 grams an hour. And then I put a little note on there about blood pressure management. We're trying to keep systolics less than 160 and diastolics less than 110. We have lots of drips in the hospital. And then labetalol or hydralazine in the field. That's also supported by the EMS protocols, but I was talking to different medics, and it sounds like there's some people who have access to labetalol and some people who don't. And so definitely, use what you have, but if you don't have access to it, of course, focus on managing the seizures and getting that mag in. So this is the EKG that I mentioned, EKG changes in TCA overdose. The reason that this is happening is because it inhibits the sodium influx through the sodium channels, which is inhibiting potassium efflux during repolarization. So that's why we're getting that. But the bigger thing to remember is what it looks like. So you can see the big wide QRS here. You can see the prolonged QTC. And then this is the little one that I also forget about all the time. They call it, I've heard it called a terminal R wave. I've heard it called a positive R wave. I've heard it just called a pronounced R wave. But here in AVR, actually, I don't know if you can see, I'm pointing with my mouse, so you guys can't see anything. But here in AVR, if you look at that R wave compared to the other R waves, there's a notch up at the top. That's what they mean when they're saying a positive R wave. And the big difference here is the treatment for a TCA overdose is push of sodium bicarb. And so that's just an important thing to remember if we're seeing a concerning EKG like that. And then this is kind of our EMS protocol on preeclampsia, with our big focus being on postpartum preeclampsia. So again, I love our kind of diagram that we have here going down of what everybody can do. We've got oxygen, obtaining IV access, monitoring. We're always doing our ABCs, and then the mag sulfate. And then they do mention, like, following the seizure protocol, definitely still do, if a patient's actively seizing, give, Versed, give diazepam, give whatever you have. But I can't underscore enough the importance of mag here for preeclampsia. And then this is the blood pressure management that I was referencing, with labetalol, the 20 mg IV over 2 minutes, repeating Q10 for a max of 300, or hydralazine, the 5 mg IV over 2 minutes, repeating Q5 to 10 with a max of 300. Okay, any questions or any thoughts anybody has? Any fun stories? Just kidding. Okay, we'll move on to case 3 then. One more time, this is the last case. I'm definitely going to finish a little bit early. I think I'm talking a lot faster than I did when I was practicing for my extremely quiet husband. So I have a 67-year-old man. He is coming into the ED. He's got a history of epilepsy. He had a seizure today. He's not currently seizing. He's been seen multiple times at UAB ED with the same complaint. What would y'all like to do? Everybody now, because we've done so many of these now. Yeah, vitals, check a blood sugar. That's awesome. Perfect. Y'all already knew this, but I'm gonna say it was my lecture that trained y'all up. So there you go. Yes, excellent. Another point, I meant to mention this earlier and I forgot to. Even if they're actively seizing, always make sure that we're checking for a pulse. I know that y'all are, and I know that when you say vitals, you are. But there have been cases where that does not happen. So y'all are so good, though, and I know you would. So just making sure we said it. But for him, his vitals are all within normal limits. He's back to his neurologic baseline without any deficit. No concern for trauma or stroke or any other thing that we're really worried about. The seizure was witnessed by his wife. She says it looks exactly like his normal seizures. No recent illness. He's not having any problems eating or drinking. We're not concerned for overdose or any other type of drugs. Though this patient was using a lot of cocaine, but we weren't really worried about it in this particular setting. He claims he's been taking his Keppra, but this is my third time seeing him, and every time I saw him, he had the same bottle of Keppra that I had prescribed him, and it was unopened. So he admitted to his medication non-adherence. He got excellent education, and in this scenario, this dream scenario, he got it way before he even made it to the ED, and he avoided an expensive trip to UAB ED. Isn't that what a wonderful fairy tale? Am I right? But common things being common with the medication non-adherence just being the most common thing in adult patients. All right. The rest I have are questions, which do we need to do them or are we doing them? Okay, just making sure. Sorry. Oh, okay. Sorry. I remember him saying have questions, but I was like, okay. Any questions from y'all or any thoughts or anything?
So one question, Doc, is over the years, we've had a lot of pediatric docs, pediatricians, kind of lean more towards Ativan for benzo for their patient population. What's the difference? Why is Ativan, or is it better, or is it preferred for pediatric patients, or is midazolam okay?
Yeah, that's a great question. So all of the the benzodiazepines that you're going to see, the classes like diazepam and lorazepam and midazolam, unless I butcher over my words right now. Oh, wait, see, now I'm panicking because I'm like, what if I'm saying the wrong thing to you? Ativan is lorazepam, midazolam is Versed, and then diazepam, I don't know the trade name for. Yep. Thank you. Wes is the best. I think that it's completely provider preference. It has to do with the time of onset of action and the time of absorption. The pediatricians that I worked with last month in the PICU were very big on Versed. I think that it's completely attending dependent and provider dependent, and I don't really want to speak on which one I would recommend y'all to give because I think that they're experts in children, and if they have specific reason, especially I know Shay During works with y'all a lot, they see so much more of it, and so if they've given a specific recommendation regarding it, I think that that's very fair. But at least in my experience, it's been very provider dependent. So I think that if you have Versed and you don't have Ativan, I think it's fine to go ahead and use. But if I'm perjuring myself, I'll let one of the fellows or Dr. Ferguson take the rest of the questions.
Okay. Right.
And they did share when I was in the PICU that there is a big gap in the research regarding pediatric versus adult, where we have so many resources for adult. We have so much research supporting the decisions we make in the adult world. A lot of the times with pediatrics, it'll be based on tradition or more anecdotal evidence, just because research is so underfunded in pediatric populations. So if you have somebody feeling very passionately about that and you say like, well, where's the data on that or where's the study on that? It simply might not exist on pediatrics. A lot of it is extrapolated from adult studies.
I appreciated that you included the case, the epidural case where the patient had a history of seizures and had a seizure. I'll speak for myself. Over the years, I've been guilty of when I have a patient with a seizure and I learn that they have a history of seizures or even frequent seizures, then I kind of automatically assume that this is going to be benign and they're going to wake up and it's been probably medication error or non-compliance, and don't really continue to look for other causes of the seizure other than epilepsy. So I really appreciate that because I think that probably happens more than we want to admit.
Oh, I'm definitely guilty of it too. And if they have blue hair, Lord help them, because I'm already jumping to conclusions. So, yeah. I think that's a great point, and you're really looking at the patient holistically and kind of trying to find the root cause, because that kind of leads to even more questions of like, well, why are you non-compliant? Is this an access issue? Is there something like UAB social work can get involved to help with? So I think that's an excellent point.
Do you find that sometimes when patients get Versed or another benzo to stop active seizures, what percentage of those patients do you think end up having to be intubated just because they get so snowed from the benzo?
Oh, I've actually only ever had that happen to me once, where a patient got so snowed from our treatment that they had to get intubated. I've even had one where this was with a toxicologist right by me. I was definitely not making this decision on my own, where we snowed them so much that we ended up giving flumazenil, which is the reversal agent for benzos. I feel like we all learn about it and nobody ever talks about it because nobody ever gives it. That is the only time I've ever given it, is because we knew we were giving benzos and we were snowing them so far. So I think that obviously it's good to go in a stepwise approach. It's always good to be cautious. It's always good to have things like in-title and monitoring and extra resources. But just in my experience, a lot of times, if they are snowed, it's kind of a mix of them being post-ictal, and it's enough to monitor them on in-title in the ED. I don't know if Tyler or Paul have any other experience with snowing somebody so bad that they get intubated.
Yeah, I think that when I was an intern, like dealing with my first like few seizures and things like that, they're always like horrifying. Oh, my bad. They're always like horrifying. Big crazy events because I'd never really seen that many seizures, except for a few in medical school, a bunch in residency. So my initial reaction was like, oh, we got to give them Versed right now. And I was with one attending one particular night, and he was like, dude, why are you giving him Versed? And I was like, because he's having a seizure. And he's like, so? He's like, is he in status? And I was like, no. He's like, how long did his other seizure last? Like a minute. He's like, let's just cool your jets. Let's just watch for a minute, because if you give this guy a bunch of Versed, if he's having his usual seizure in the setting of known seizures, particularly in like non-compliance or some kind of triggering event that's not something catastrophic like a brain tumor or a bleed or something like that, he's like, why don't you just take a step back, breathe, and watch them for a second. If you're concerned that this is going to be like a 5-minute seizure, they start to get hypoxic and things like that, and then sure, let's try to break the seizure. But the seizure in and of itself sometimes is not that big of a deal. It's the complications that come from it. So if you have a patient that is maintaining their oxygen saturations and things like that, they're having their usual seizures in the setting of a known history with a provoking event, sometimes Versed can kind of prolong an ED course, set you up for those kind of complications like hypoxia or a loss of their airway, things of that nature, hypotension, what have you. It doesn't always have to be your automatic response is to load them up with Versed and sedate the crap out of them, because you might wind up dealing with one of those complications. Like I said, this is all in the setting of like, this is a known thing for this patient. If this is a new thing or this is status epilepticus, that's different. You have to do this and you have to break it because these people are getting into trouble. But this might be one of those situations where you can take a breath for a second and say like, hey, as long as our vitals and our oxygen are okay, we don't have to run off and give these benzos instantly, if that makes sense.
No, I think that's a great perspective from both of you. So in the EMS context, we oftentimes have very less information than you're getting in the ED. Would all the docs say that it's fair to suggest that if we're on a scene out of the hospital, the patient is actively seizing, then they should get a benzo?
Yeah, I think that, yes. I think especially there are cases like that Tyler was describing, or Dr. Sullivan, sorry, was describing where if they're abating in 30 seconds and by the time you've pulled up the med, they've already stopped, yeah, you probably don't need to give it in that case. I think you bring up a great point, though. This probably should have been an extra case, but I swear I was at time when I was slow and calm in my own home. But and when I was in the PICU, we had a lot of Legacy of Hope walks. We had a lot of children who did not make it. It was a very sad month. And one of those children was a girl who was in status, and she had a hypoxic arrest because they couldn't break her seizures. And we looked at, this was at an outside hospital ED. It was not, she started seizing in the field. The medics were giving the appropriate Versed, but they maxed out. And then in the hospital, I think that because she was a pediatric patient, they were really concerned about doing too much. and they were unable to break her seizures. And because of that, she arrested. She continued to have seizure activity while she arrested. I think that there was a delay in realizing that she had lost a pulse. And by the time she made it to the PICU, it was a completely anoxic injury, and her family proceeded with organ donation. So I think that that is a really sad case, but it's a really good reminder of I think that in pediatrics especially, we get a lot of mindset and mentality of like do less, because pediatric medicine in general is a do less approach. But in that case, there was definitely more that could have been done, and it would have prevented the poor outcome that she had.
Yeah, I'll say all that to say, so it's important that you're able to recognize and differentiate like seizure from status epilepticus, right? Because a status patient has to have those things. But if the seizure is abating or the seizure's stopping by the time you're drawing up these medicines or getting ready to administer it, that's the point where you could say like, hey, I'm just going to hold this here. I'm not going to give it at that point. If it's been a substantial amount of time, like 2 minutes have passed, or like I said, any kind of abnormalities on their vital signs, that's the time when you would give it. And you're not going to be wrong for giving it. Like if the patient has a bit of a prolonged postictal state because of some benzos, it's really fine. Just be prepared to intervene on, any complications that come from that. But this is an important point on differentiating between like a seizure and status. But also knowing that if you give that medication while an active seizure is going on, you're not wrong. So I don't want you to think that I'm saying that you might be for giving Versed for an active seizure or giving a benzo for an active seizure. So just want to make that clear.
Got you. All great information. So one last question. So how often do you see seizure activity that's related to a patient whose underlying patho is ischemic stroke? Is that something that you see at all?
It's definitely possible. If you were to ask me personally, Callie, how many times have you seen seizures related to a stroke? I haven't. I've seen it in pediatric patients. I've never actually seen it in adult patients. And I'll definitely let Dr. Kirby and Dr. Sullivan share any of their cases that they might have. But usually when they're stroking out, they look more like a stroke, personally.
Yeah, I would say if they're having an ischemic stroke and they're having seizures, they look pretty bad, and they're going to get tubed regardless and get treated and get to the CT scanner. I don't know if I've seen too many where I'm like, oh yeah, that's an ischemic stroke seizure right there. I think they look pretty bad when they show up, if that makes sense.
Yeah, usually something else has occurred, or like there's already an indication that there's a stroke. But yes, that is a known sequelae or complication of stroke, particularly in the right areas. So if you have like a big temporal lobe infarction, or you have like a massive hemorrhage or something along those lines, like you'll see seizures pretty routinely. But typically, like seizure is not going to be the presenting issue from like an ischemic or hemorrhagic stroke. There's gonna be other stroke signs or symptoms beforehand. But yes, that any kind of infarction like an ischemic or hemorrhagic stroke that disrupts those cortical pathways, that can kind of send you into like, what is a seizure? It's this chaotic firing of neurons and things like that. So anything that can infarct or disrupt those cortical pathways can trigger a seizure, particularly when the infarction occurs in locations that make you prone to that. So yes, it is a complication of seizure, and you'll see it particularly in a massive stroke or a massive brain bleed. But somebody could have a tiny like temporal lobe infarction that triggers seizures more easily. Long story short, yes, you will see that, but it'll be a secondary outcome or complication of the stroke itself, and not necessarily the presenting factor.
I feel like when we talk about it in the ED, or when we see it in the ED, it's like after they're shooting. It's usually like somebody's already been tubed, and we're like, oh, they're having, like, a lot of times it'll be like they had seizure activity, they got tubed, and then we're getting all these scans, and then we understand that they had a stroke, and it was because of that.
Yeah, I've actually run into that a couple of times, and for me, it's been it came in, they're having signs of stroke. During the transport process, they start seizing. I give benzos because they're seizing. It seems like it complicates the stroke care and diagnosis, and it makes me wonder how many times people have seizures when they had it's a stroke, and we just don't get that part of the story. And then that could affect the logistics of routing the patient and all that sort of thing. So,
You can almost flip it too, right? Like I know I've gotten got by like a Todd's paralysis. So in other words, someone had a seizure, and then by the time you get there and you're on scene, they can't move the right side of their body, or like they're aphasic or something. You're like, oh, this is a stroke. And sure enough, they show up to UAB. We do all the stroke things. And then you look through the chart and they have a history of seizures, don't take their medications. And this is very common for them. But it's one of those things that I would rather be made fun of for calling a stroke on a Todd's paralysis than the opposite. You know what I mean?
yeah, definitely. Very good. Thank you, Dr. O'Brien. It was a great lecture. We really appreciate you. Everybody, we're going to take a break, but let me remind everyone to please fill out an attendance form for today's event. If you're watching online, you can find the link to the attendance form in the Q&A section. So everybody stretch your legs, and we'll be back in a few minutes with Dr. Sullivan.
We'll run through this because lunch is next. This is like the 18th installment of Cases in Resuscitation. So you may have heard these cases or similar cases before. You may have even heard them from me. So you may tune me out just because you're over it and you're just cashing in that CME, or you may tune it out because you've already heard it before or whatever. But regardless, we're going to talk about them again. Since there's been so many cases in resuscitation talked about over the past year, that thank goodness that this present academic cycle is about to be over with. It goes like basically July 1 to June 30. So we'll reset kind of in July, but I know this lecture's been given a few times. So I tried to pick like the highest yield, highest acuity cases that we could see, utilize that I think would be useful to your daily lives. So we'll jump right in. So objectives today is to kind of recognize early signs of critical illness, and particularly in common critical illness. I considered doing a hantavirus lecture or Ebola or some kind of tropical medicine stuff, but it's decided we would just switch into high yield stuff. So but maybe hantavirus will be high yield in a few weeks. Who knows? The rat poop virus. We'll see. But anyway, we'll look at high yield kind of interventions under pressure. We'll talk about some resuscitation pearls and pitfalls, and just general stabilization. So the lecture slides will be general. Since we've talked about these, we've covered every one of these subjects in detail and in cases this year. So if you want to deviate off the path and ask questions and talk about a little bit more of the nuances, I would actually love that. So let's do it if we can. So luck is what happens when preparation meets opportunity. So some preparation via cases. So let's go. This guy in the first case is going to be a 24-year-old on his donor cycle, was riding, and he ran off the road and hit a guardrail. This is actually modeled off of a case that we had at UAB. So he's found on the ground. His face is jacked up pretty bad. He hit the guardrail, squared it up, wasn't wearing a helmet. So his face is split, part of it's hanging off. His jaw is obviously jacked up. And if you were to do an astute physical exam and you grabbed his upper teeth and moved it around, the front part of his face would move a little bit while his head stayed still. So we call that a Lefort fracture. So you're seeing some evidence of Lefort fracture. He's like gurgling. He's not breathing super well. You throw a SAT probe on him and he's like 78%. He's tachycardic. He's not breathing very fast, and he's hypotensive. He's confused. He's showing all the signs of malperfusion. So what are your initial thoughts about this guy other than that he's pretty jacked up? He might indeed. So our initial concern is that this guy has probably hemorrhagic shock. He's got impending airway failure with evidence of like multiple routes of obstruction via like blood, probably some blunt lung injury, and also his face is jacked, so the anatomy is obstructing it as well. So what are we seeing? So we're identifying early via our ABCs, right? When things are high stress and high octane and people are looking at you and blood's everywhere and all that kind of stuff, when your pulse rate is high too, I like to keep things simple because don't do complex things, at least intellectually, super well. I like to keep them simple, keep them on a roadmap so that I don't have to think about as much stuff, right? So our ABCs, airway, breathing, and circulation. So if we're starting there at our airway and breathing, we're seeing that both of these things are compromised, right? He obviously has like blood and anatomy or anatomical obstruction for this guy that's causing hypoxia. He's not moving air. You obviously hear all the gurgling sounds and you can see the external signs of trauma. Big things in these patients is that, like a healthy patient with a healthy lung, like it doesn't take much to oxygenate them, right? So room air right now is like 21% FiO2, something like that. So there is not a whole lot of oxygen relative to what all else is in the air, right? But we're all sitting here at 98 to 100%. Folks with sick lungs, whether that's from like COPD, trauma, whatever, not so easy, right? So one of the best things that you can do in this situation is go ahead and initiate your pre-oxygenation, right? So even if this is like a first arrival BLS crew, with kind of limited interventions on what they can do, they can help get this guy into a better position, maybe prop open his airway a little bit. If his face is jacked, they can still help move some of that anatomy out of the way, put non-rebreathers, nasal cannula on this guy. And if you have enough hands, we can get a bag valve mask and try to oxygenate this guy as best we can and assist him with respirations. A notable thing about airways in this situation, as we noted, this guy was hypotensive and hypoxic and tachycardic, so he's showing a lot of signs of some issues, right? He's obviously got some upper body trauma with the external facial injuries, so we can assume that he's taken kind of some thoracic trauma as well, right? So there's potential for pneumothorax, there's potential for hemothorax, and a lot of increased pressure in his chest, right? So what do we not want to do for this guy right off the bat, right? Given his hemodynamic status, what do you think would be a thing that seems like it might be an answer, but would be an unwise move? Baggins probably okay, right? Because so it could, yes, but there's a risk and benefit here to this guy, right? So his respiratory rate was 8, so he doesn't have great effort anyway. So you've got to help this guy out somehow, right? But a big contraindication right now with him being hypoxic and shock, or hypotensive and in shock, is to increase his intrathoracic pressure, which is what you're getting at. You've got to kind of play both sides of this, right? Like you don't want to run off a bunch of positive pressure in there, but yeah. So we would get there if we were suspicious for a pneumothorax, but the general concept we're getting at here is like the pressure is increasing in his chest most likely. So intubating this guy or really giving him a lot of positive pressure from that standpoint is gonna hurt him. He's hypotensive as well. He's tachycardic, so he's in sympathetic overdrive and likely kind of reaching the end of his ability to compensate right now, right? So he's probably lost a lot of blood. So he's relying on that sympathetic tone to maintain the little bit of perfusion that he's got. So if we load this guy up with RSI drugs, so we give him a bunch of ketamine, even though ketamine doesn't do it as bad as other agents, we can still pull that little bit of sympathetic drive away from this guy as well. So you would do two things with RSI in this situation. You would increase his intrathoracic pressure, and you would take away some of that remaining sympathetic tone that he's relying on. So in this situation, intubation arrest risk is extremely high. So you'll want to focus a little bit more on the resuscitation despite the airway and oxygenation concerns that you might have. Resuscitate before you intubate is kind of the little quip that people like to throw out, but it's actually like, it's what you need to do. This guy needs blood. This guy needs, some kind of volume resuscitation, to improve his kind of hemodynamic status before you start adding that stuff. So all to recap, this guy, he's got a bunch of upper body trauma. He needs resuscitation. He needs airway. But we got to use our adjuncts in this situation until we get him kind of adequately resuscitated. So facial trauma can be nightmare stuff, right? Like the stuff is freaking nasty, nightmare fuel, right? It can also be extremely intimidating for us as providers or professionals. I don't really like provider that much. I prefer like professionals, or call it what you are, clinicians. But these can be really intimidating and really awful. I actually put the photo on the right in. What do you think might be wrong with the photo on the right? What do you think might not be a great idea? Yeah, they jammed a bunch of nasal trumpets up in there. Why would that be? Why could that be an issue? Yeah. So if he's got skull base fractures, if he's got big fractures through the cribriform plate, even though those are not rigid at all, they're pretty flimsy, you can still cause some other issues, and you can wind up bagging this dude's brain. Yeah, I'm not real sure. The whole thing is kind of weird, which is why I saw that one on Google Images, and I was like, let's put that in there. A lot of weird stuff happening in that situation. I don't think that's the route I would have gone, but maybe it worked out for him. So anyway, kind of recap big facial trauma in the setting of needing an airway, right? So our BLS priorities. So if you guys are first on scene, you want to try to get this guy suctioned out and try, he's got a lot of gurgling sounds. He's obviously pooling secretions, blood, vomit, what have you, in the back of his throat. So you want to get him sucked out. You want to have as much suction available as you can. You want one for you to drive around. And if you're doing an intubation on scene, you want to have one that you can jam in there and suck as much of that blood out while you're looking as well. So you want to have at least 2 points of, you got to have one, but you want to have 2 points of suction available to you to aggressively suction these guys out so they don't drown in their own secretions and fluids. Jaw thrust and positioning. So one thing that you could easily do for this guy, if he's shattered his jaw and everything here is like lost its structural support and all that soft tissue is falling backwards, you can elevate this guy's jaw and pull some of that tissue away and open up that upper airway to help him move air a little bit easier, especially in the setting of poor respiratory effort. The OPAs and MPAs, as we just kind of talked about, like you got to know when these things are viable and when they're not. If somebody's face is jacked up like that, I probably wouldn't go sticking an MPA in the guy's nose, just because of the risk, like we were saying, of skull base fractures and causing further damage. But if you can find something like an OPA that might help you prop that stuff up, an OPA shouldn't cause you much of an issue. So if you are bagging this guy while you're anticipating, a more invasive airway, getting anything in there to help you move the anatomy and all the stuff that's sitting back there away from the airway itself, is going to help you out. If you have enough hands on, you want to have the two-person BVM still, right? So you've got one person holding the still, lifting the jaw up, and the other person giving good adequate breaths here. So that's kind of our basic priorities here. As far as ALS goes, so once the paramedic arrives on scene and you're going for the intubation, you want to make sure that you've got good pre-oxygenation. One thing that I like to harp on is the passive oxygenation, and I know that's one of Dr. Ferguson's things. So this guy should have a nasal cannula on him pretty much throughout the whole process, whether you're using a non-rebreather or a bag as well. You want as much oxygen flowing as you possibly can. There's plenty of studies that are out there that show this apneic oxygenation can actually extend your safe apneic time. So I don't think there's a whole lot of reasons to not have at least a nasal cannula on these people wide open, regardless of what you're doing. I think it can only help you and not hurt you. You want to make sure you resuscitate these people right. So if this is a guy that's in hemorrhagic shock or septic shock or whatever kind of shock you can throw out there, you want to resuscitate these guys first and make sure that you're in a good position and that your help, as far as an airway goes, is not going to hurt. Bougie and video laryngoscopy, I know that, there's guys that have done direct all their lives, and then there's people who have done nothing but video. The main point of your airway assessment or airway equipment and intervention tools is that you go with what you know. So if you're a bougie guy, be a bougie guy. Just embrace the bougie and use it every time. If you're a video guy, use your video. If you're a direct laryngoscopy guy, but you think that you probably should go to video, do what you're comfortable with, do what you find success with, because that's ultimately where you're going to find your success is doing what you know. But get your reps in with video if you're planning to make that transition. And then anytime you establish an airway of any sort, put them on Entitle. Entitle is going to alert you to an arrest, especially if you have like a patient who's paralyzed, whether that's due to drugs or a big bad brain injury. That Entitle CO2 can alert you to many things. It can alert you to a missed airway, a dislodged airway, or a cardiac arrest that you don't necessarily have your finger on the pulse for all the time. Say a patient goes into PEA or something like that, you're still seeing electrical activity on the monitor, you're in between cycles on your blood pressure, that Entitle dropping from 36 to 9 might be the only thing that alerts you immediately to your cardiac arrest. And then of importance, it also covers your butt too. So if you show up to the ER with a patient that's really jacked up and you've established an airway, at some point in their resuscitation, that airway becomes dislodged. And then this case comes up a week or two later in QI, and they're like, we think they brought us in a patient with a dislodged airway. And you whip out the strip of good Entitle readings, and you're like, no, sir, we had the airway, and we had it confirmed. That's something that'll cover your butt as well. So that's certainly not off the list of reasons to do Entitle CO2. Is for protection for you as well. Number one, protection for patient. Number two, protection for you. Once you get inside, this is some things that you might see, which hence the importance of good suction. The most important thing about establishing an airway in this situation, like I said, is knowing your tools and going with what you know and having good available suction. The point of the game is to win, so you always want to set yourself up to win and have as many things there with you as you can. If you're going to go for a crike, knowing your landmarks, you can easily find them on your cells, but in this room, most people are healthy. Lots of people who need crikes are not necessarily healthy, so those landmarks might not be as prominent. But finding your own, a lot of times, will at least get you some idea of what things feel like, right? So if you stick your thumb in what we call like the goozle, or the sternal notch there, and you go for the males, you'll go over a first point, and then you'll kind of land up underneath your Adam's apple. There's a little divot there that you can feel, and that's your membrane that you're wanting to go for. But getting your hands on in these situations and feeling for that anatomy, especially if you have a patient who's like obtunded and intubated and things like that, nobody's going to fault you for making sure that you know where your landmarks are, and getting a rep in when you can. But if you can get into like cadaver lab with us and things like that, that's another chance for you to kind of explore that anatomy and know where to cut and where to go. But that's another talk for another time. But generally, you're going through here over the top of that membrane, making a vertical incision, a sideways stab, and you're going in either with your pre-made tracheostomy kit or cricothyrotomy kit, or with a bougie and then an ET tube if that's what you got. So kind of knowing your equipment again, knowing your anatomy, and knowing the steps can make this happen. The scariest thing about doing a crike is making the decision to do it right. So knowing how before you go into it and when is the most important part. The decision is the most difficult aspect of that. So kind of takeaways from that, like when we're doing these big dramatic airways, oxygenation many times matters more than getting the tube right away, right? So making sure that the patient is set up for success, that you're not going into this with a hypoxic patient, and having good backup strategies for how you're going to keep this patient oxygenated, critical importance. You need to have suction available, especially in the traumatic airway, because there's going to be blood. If you get in there if you're a camera video laryngoscopy guy and you get in there and there's nothing but blood and it gets on your camera, now you're blind. So you need to have suction available for you, preferably 2 different routes of suction. So 1, you can suction as you need to, and 2, you can jam that down in the esophagus to where it's constantly suctioning fluid out. Being conscious that traumatic intubation can be the thing that pushes them over the edge and kills the patient ultimately. And so being aware of, or being conscientious of your resuscitation beforehand and setting yourself up for success, and then being ready for alternative airways, whether that's aborting the ET tube and just going to bag, putting in a supraglottic airway, or worst case scenario, going to the crike. just being prepared to go any direction once you start down that pathway, and being flexible, but being conscientious and well trained on all of those. So that is trauma airway, facial trauma management, on a base level. So any questions, anything like that, any dive off in the weeds that you guys want to go, we can. I know I spent a little more time on the first topic than I intended to, but yeah, so would be difficult to go too far with a supraglottic airway, just as long as you're using the right size. Once you get into the adult realm, there's really not a whole lot of deviation. The pediatric ones matter a little bit more, but that's the importance of having like a Braslo tape and color codes and things of that nature. But that's another kind of, I guess, plug for end-tidal CO2. If you hook that LMA up to end-tidal and you've got a good waveform, then you can rest assured that you're in a good place. So that's what I would say about that. Difficult to go too far, not difficult at all to be too shallow. So being aggressive with insertion is kind of one thing, strange as that sounds. Any others? Cool. All right, case 2, 54-year-old guy collapses while exercising at a local gym. Bystander CPR is in progress. Good prognosis from that standpoint, or best available. The patient is pulseless with VFib on the monitor, so he gets multiple shocks, he gets epi, he gets amio, he gets all those things. You get ROSC after about 12 minutes of dealing with this guy. But despite return of pulses, the patient remains unresponsive. He's hypotensive, he's tachycardic pale, showing obvious signs of malperfusion, right? So classic witness VFib arrest, right? And this guy's lucky that his buddies on the street decided to do chest compressions on him. These are the most salvageable when like a sudden VFib arrest occurs, is when the patient gets good quality compressions right off the bat, and then EMS gets there in a timely manner. So ROSC here, good, everybody's happy, but that's kind of like, I like looking at ROSC as kind of like the getting over the first hurdle, right? So once you get ROSC, now you can start taking care of this guy. Once you've got the pulse back and actually have an alive patient, now you can really start your resuscitation, right? That's when the resuscitation part begins, in my opinion. So during the arrest, so you get all of this global ischemia, right? You burned up all of your oxygen stores. You're now in this obvious like anaerobic metabolism, whatever your tissues are trying to survive at this point. So you're rapidly reducing the ATP, all of the energy sources of the various cells and tissues, and you're switching over to this anaerobic process that's driving your lactic acid up sky high and decreasing your pH very, very rapidly, which makes the entire rest of the resuscitation much more difficult to deal with. So you get this big bad metabolic acidosis, which makes your medications less effective, which makes your cardiac induction less effective. It puts you in an even worse spot than you already were. Once you get that ROSC, right? So once you've got a pulse back, these patients are obviously really, really sick and have potential to be much more difficult to resuscitate than a similar patient with similar vitals that had not just died for a while, obviously. So what you see here, interestingly, is this inflammatory like reperfusion injury. So what happens is these cells, they undergo a prolonged period of ischemia, and so they generate all this lactic acid intracellularly as well as extracellularly, and they have none of those ATP molecules, the kind of energy transport of the cell. And so all of a sudden you get this big resurgence of blood flow to these areas. You get all of this oxygen back, and you start to see some interesting things happen. So you get this reperfusion injury. And what is that? It's kind of similar to sepsis. So if you know sepsis is kind of a syndrome, right? So when a person gets an overwhelming bacterial infection, they release all these inflammatory cytokines. You get all these like reactive oxygen species and these free radicals, all of these inflammatory mediators that cause end organ damage, endothelial dysfunction, They cause a bunch of vasodilation, so you drop your blood pressure, and things get harder to resuscitate at that point. And similarly, once you reestablish all of this perfusion, you get a similar type syndrome. You have all of the same mediators that are going out. You get all the same endothelial dysfunction. That's why a lot of times, like when you resuscitate a patient after a prolonged arrest, within a day or two in the hospital, they're blown up like balloons. They look like they're volume overloaded. They look like a water bag because they get all of this endothelial dysfunction. So that makes things much harder to deal with from that standpoint. So during the arrest, obviously, like we're focused on high quality CPR, we're minimizing interruptions, we're defibrillating when appropriate and giving appropriate medications. After the ROSC, is when we kind of get into more of our detailed resuscitation. So immediately thereafter, you want to get a 12 lead and want to see what you're dealing with. Is this an MI? Is this something that we have to switch and get them to an appropriate center? Are there more medications that we need to do? Really focusing on kind of like what caused the initial arrest. Like I said, treating this physiology can be quite difficult sometimes, which is where you want to be early with vasopressors and things of that nature. Sometimes if you get a really, really hypotensive patient after a cardiac arrest and you have this reperfusion injury, you might have to go to pressors earlier because fluids might not do the trick because of vasoplegia. And that hypoperfusion is going to cause worse outcomes from any organ standpoint in the body, right? So hypoperfusion or hypotension in these ROS patients is going to cause more of brain damage. If they suffered any kind of anoxic brain injury beforehand, if you have ROSC and you leave them hypotensive and malperfused, you can worsen that injury and cause them to have a worse neurologic outcome. Similarly, for your kidneys, your liver, your bowels, your heart, the longer they go without adequate perfusion, the more sustained damage that they're going to have even in the post-ROSC state. So really focusing on aggressive resuscitation is going to benefit you generally in every organ system in these patients. The more you can resuscitate and the better you can perfuse these patients, the better the outcome is going to be long-term down the road as far as their functional outcomes go and their long-term complications in pretty much any organ system. Just a quick review of like our rhythms. This is kind of the most common ones that you're going to see. Your VFib arrest, asystole, VTAC, and PEA, and just pop those in there just to make sure that we're reviewing those closely. The biggest one that you're going to see, like VTAC, you're going to recognize. PEA, you're going to recognize. You're going to have this nice electrical activity on the monitor. But asystole and fine VFib is a place that seems to be getting a little bit more attention lately. There's been like a resurgence of the conversation of like, if we're coding a patient in the ER that's asystole, is there utility in defibrillating these patients? Is this like fine VFib that we're not picking up as well that we think is asystole? And so being kind of conscientious of, is this fine VFib or asystole, and delivering a shock when you suspect one or the other. But knowing that in the protocols, if you shock somebody, typically that means a transport, right? So if you're at the end of a big resuscitation that you've been treating as asystole, like being conscientious of like what happens after that shock, if we're just going to shock asystole or if we actually think this is fine VFib. So I wanted to add that caveat, but a lot of interesting conversation going on there, but just being conscientious of your rhythms there. So cardiac arrest and ROS, right? So the big things to kind of focus on here is like inside the arrest, your CPR is going to be the biggest correlation with your survival. So focusing on good quality compressions and minimal interruptions. Hyperventilation a lot of times can cause like some of that free radical formation. You want to avoid over ventilating these patients. End-tidal CO2, I think you should have this on as early as possible, when possible in any resuscitation. This is going to be one of your best tools for in resuscitation care, and ROSC is not the end of resuscitation, right? It's really the beginning, in my opinion. So the bigger takeaways, kind of your secondary, is like your hyperoxia is interestingly associated with worse outcomes. So paying attention to how much you're bagging the patient. I know, especially in the post Ross situation, I guess your adrenaline's pumping too, right? So don't overbag these people. But usually in your transports from like a place like this to UAB or to wherever you're going to take them, it's not that long. So that's not really that big of a focus for you. This is more of a prolonged transport concern. You really want to focus on avoiding hypotension in the ROSC patient. You want to focus on correcting their hemodynamic status as quick as possible, whether that's with push dose epi, bridging into some levo or an epi drip or dopamine if you still use that. But trying to minimize that time and not like stopping and taking a breath after you get ROSC and saying like, okay, we're good, let's take a breath. Really being aggressive as soon as you make that transition from cardiac arrest to ROSC. If you've identified a STEMI in a quick, rapid EKG post-ROSC, changing plans if you have to and getting them to a STEMI center is of utmost importance in this, just because of the time frames that we need to intervene on these folks in the cath lab. But as far as the fourth point goes, don't worry so much about that. It's more of like an in-hospital type thing. So your biggest things, to take away from this as far as ROSC care goes is making sure that you're not overventilating the patients, making sure that you're extremely aggressive about correcting their hypotension, resuscitating them from that standpoint, and getting them to appropriate centers based on what you think is going on, making sure you're getting an early EKG. Any questions about post-ROSC care? Yeah, I think it's great. I don't, off the top of my head, have the evidence to say like it's better or worse. But in particularly in a refractory VFib case, I do it every time. Especially after like 2 to 3 shocks and I'm not getting the patient out of a ventricular arrhythmia, something's not working. So that at that point I start thinking more about like out of the box solutions. Like, is this patient's pH like below 6.5? Do they actually need bicarb? Like, even though bicarb doesn't show like, increase your vital rates, I'm like, is there some reason that I can't get them out of VFib? And so I start going to those things. So I start doing dual sequential, I start doing bicarb, I start doing calcium and all of those things that they could be adjuncts. But I totally agree with it and love it. Sometimes I haven't focused as much on that. But usually, like, what are you meaning by that? Yeah. So usually when I do the dual sequential, I'm doing AP. Some of the places that I've worked, the pads will be essentially AP to start with. But if I'm using kind of your standard placement, the first shock is standard and the second is AP.
Hey, Doc, I appreciate you mentioning to avoid hyperventilation. It's a big pet peeve of mine for people to hyperventilate with artificial ventilations.
Yeah, I don't think there's been, even in like traumatic brain injury, when theoretically like blowing off more CO2 would cause vasoconstriction and decrease your intracranial pressure, which seems like it might be a benefit. I think pretty much across the board, overventilation is shown to have worse outcomes, regardless of what it is. So being conscientious of that, because I know I'm the worst about it. Like if I'm hyped up after like an extremely difficult airway and RT's like, hey, will you bag them while I get the tube secured? I'm over there like, so I have to try to say like, I'm going to bag this patient as I breathe, unless I'm breathing really fast too. And then I just try to go slower than I'm actually comfortable with.
So after ROSC, do you think it's good advice to adjust your ventilatory rate based on end tidal CO2 readings?
I think that's fine. But if you have ROSC, you should presumably be able to get an O2 sat. Sometimes you can't, like especially if they're hypotensive and their hands and feet are ice cold and things of that nature. But I think that's fine. Just be conscientious of like, don't go chasing a number. Don't overventilate a patient based on what their end tidal says. Because that could in and of itself be a danger. Like I've seen end tidal be wacky. You know, I had a patient we coded the other night that her end tidal was 19, despite her blood pressure of 160 over 100. Like her end tidal just stayed 16 and 19. Couldn't really explain why. And I've seen them also have like 50s and 60s. And so you want to change your ventilation based on that, but then you get an ABG back and their, you know, PaO2 is hyperoxygenated at 20 and you've blown all their CO2 off and you're like, well, it's not actually like a ventilation issue. I don't know why. But sometimes it happens. So that would be the danger in titrating to an end tidal is over or under ventilating when that's not actually what they actually need. So
Yeah, fair enough. I mean, I think I would suggest, you know, if they're post-ROS, generally their end tidal is going to be elevated
Yeah.
for a few minutes. And I would suggest maybe increasing ventilatory rate slightly to maybe once every 4 or 5 seconds instead of once every 6 seconds.
Oh, yeah.
Until
I think
it
that's totally reasonable.
normalizes.
I'm with that.
All right, very good.
All right, gunshot wound. 22-year-old guy shot in the groin. So not really a place that you can intervene on too well, right? So it's in a junction. The pelvis, when I did gross anatomy as a first-year med student, the pelvis to me looked like they had like this professionally hemisected one, and it looked like a bowl of noodles with all the vasculature that's down there. It was very intimidating with how much arterial and venous vasculature is down there. So these people bleed, right? So this guy's shot in the groin, presumably into the pelvis, and he's quite sick, right? So he has pulsatile arterial hemorrhage noted from his proximal thigh. So there's a chance that he has damaged one of his more proximal great arteries in the leg. His heart rate is 148. His blood pressure is 72 over 40. And he is confused as well. So he is showing signs of global malperfusion. So he's in trouble. This guy obviously has a big exsanguinating hemorrhagic shock. He has a big bleed and a big problem right now. So without hemorrhage control in this guy may arrest in the next 30 seconds, a minute. Usually if you see a patient like this that is freaking out in extremis because of blood loss, they have been circling the drain and now they're pretty close to going down. So you've got to be particularly astute and proactive in these situations. So the priority now is going to be resuscitation and trying to stop this bleeding, right? So what happens when you start to bleed to death, right? The first thing you're going to see is mild tachycardia, maybe some tachypnea, but pretty much tachy anything, right? Once they start to speed up and have evidence of something that could make them bleed, you need to start perking your ears up. We call it an early sign, but in reality, particularly in young and healthy people, this is getting on down the line once you start to see hemodynamic changes. Once you lose more blood, you start to get more hypoxic as far as your tissues go. So you start to switch over, like we were talking about, to that anaerobic metabolism. You start to generate lactic and you start to decrease your pH. And you can see some myocardial dysfunction as well because of the hyperdynamic activity, right? So this is getting way on down the line when you start to get real depleted. What that results in is you get into the trauma triad, right? So we've heard that, I'm sure, 1,000 times. You get acidotic, you get hypothermic, and you get coagulopathic. And all of those things act on each other to make things worse, to work against you and the patient and limit your ability to resuscitate this patient, right? So here's kind of the schematic, right? So you start to lose blood, you start to get colder, you start to spend all of your coagulation factors, and so you start doing a worse job of stopping the bleeding. The more you bleed, the more hypoperfused you get, so the more lactic you generate, the lower your pH goes, the less your clotting factors work, the more clotting factors you spend, and the cycle continues, right? So you also get cold, which doesn't help in these situations either. That's why the trauma bays are so hot and you sweat whenever you bring patients in, because we want to keep it as hot as possible. So that's the triad, right? So you get stuck in this, like, essentially irreversible coagulopathy cascade that limits their ability to stop the bleeding, making the bleeding worse, and they get into trouble, right? So your immediate priorities in these situations, if this is an extremity injury, you're throwing on tourniquets and you're doing your best to stop the bleeding. You're holding direct pressure on sites that you can't really tourniquet, or you're doing both if you can. This guy has an injury to his groin, right? So we're not going to really be able to put a tourniquet on this guy. So in this situation, your immediate priority is going to be direct pressure as hard as you can. It'll be very uncomfortable for this guy. If the wound is big enough, pack it. Jam a bunch of combat gauze in there. And this is a barbaric activity to do to someone who's conscious. But the reality is that these folks need it. So once you have held pressure for however long you're comfortable with doing that, hopefully not long, and you're not having success, you want to jam that wound as tight of combat gauze or some kind of hemostatic agent as tightly as you can, and then resume that direct pressure. So once our paramedics arrive on scene, we're going to start to focus on like giving them TXA, trying to help stabilize clots, which is kind of the physiology behind that. TXA is a clot stabilizer, and it helps prevent further clot breakdowns. You're trying to break that coagulopathy cycle. If you have blood products available, which is the super hot topic right now, you want to give them blood. That's the ideal thing to do in the state. But if you don't have blood, our patient is critically hypotensive, so he needs something. So it's not wrong in these situations to give crystalloid if it's all you got, if the patient's blood pressure is 60 over nothing, right? If this guy's blood pressure is more in like the 90s, right, upper 80s or something like that, that might be a situation where we allow a little bit of permissive hypotension in the situation, because a lot of times your crystalloid can worsen that coagulation cascade, right? So it can make you more acidotic. It can dilute your clotting factors and make things worse. So there's a bit of a game to play when they're hypotensive, right? It's like, how hypotensive are they? Is the patient in extremis and have a blood pressure of like barely detectable? Then he probably would benefit, or at least it wouldn't hurt you too bad to give this guy some crystalloid. So I'd recommend you do that. I'm not saying flood him with like 2 liters on the way, but giving him a little bit of crystalloid and trying to get him some volume back so he can try to perfuse is a reasonable deal here. Ideally, you're giving this patient whole blood or PRBCs. The thought behind whole blood being you give volume expansion, right, which is what he needs to support his blood pressure. You give them back PRBCs, which are kind of your oxygen carrying capacity. So you give them the red blood cells that can carry oxygen to tissues, and you get the plasma, you get all of the things that come along with that. So you're restoring the clotting factors that are spent that aren't really coming back. So whole blood seems to be the kind of catch-all that has all of your factors. It has volume expansion and oxygen carrying capacity. So that's the one you want to reach for if you can. Obviously, in a patient like that, you want to get them to definitive care as quickly as possible. If that's UAB, great. If you're 30 minutes south of here and you need to stop for some resuscitation at another hospital, that might be what you have to do. But getting this guy to the right place where there's a surgeon is where we're going from here, right? So all that to say, like, this bleeding obviously kills rapidly, but not just for the reasons you think, not just because they're bleeding out, but because you get into that trauma triad that really hurts people. So tourniquets and wound packing can help save lives, right? So packing this guy might be one of your difference makers if this is like a femoral artery injury and you get a bunch of wound packing in there and you get a ton of pressure on top of it. Maybe you can slow that down or stop it, at least to the point where he maintains what he's got to get him to definitive care. Crystalloid overuse can worsen outcomes, but crystalloid might be reasonable given the situation. So don't take that statement as solid gold, right? Yes, it's not ideal, but it's not the end of the world if it's all you have. And time to surgery matters. So making sure that you're moving, not delaying transport, not delaying care for this guy to get him to where he needs to be is ultimately what this guy's going to need, right? So any questions about that? is whatever you got. You're never going to be faulted for trying these things, right? A junctional tourniquet, if you've got it and you feel like it could be adequate, heck yeah, throw it on. Abdominal binders, I don't know how much they actually do help, but like I said, if you throw one on, that's not going to be what kills him, right? So all of those things are reasonable thoughts, and I think are totally reasonable to do in these situations. Do I think like a binder or something like that is going to save this guy? Like probably not. Particularly in like if you're binding the pelvis or something like that. If it's just a penetrating injury, there's not going to be that compression that you would get with an unstable pelvis, and so theoretically your benefit would be less. But anything that you can do that you think is going to help you get some pressure on a wound, I think is totally reasonable.
Hey, Doc, we've seen some success in Western Europe with the use of Reboa, even pre-hospital, where they, particularly for injuries like the one you described in your case. Is Reboa something that's being done or considered in clinic at UAB? And do you ever see that being a out-of-hospital procedure?
Out-of-hospital procedure, it's hard to say. So the reason they're able to do it is because the systems that they employ oftentimes have physicians in the field. So like where EMS 4 shows up here, that's going to be like a physician. Also, most helicopter flights over there are going to have a physician on board. And so a lot of times you've got these folks who are highly specialized that do these things. So I think there's a lot of hurdles to overcome in the way of getting things like that done, just because for many reasons. I think one, logistically, having the training and getting it done, paying for it, and also the medical legal environment of the United States. Like, you know, the question of like liability for an invasive procedure like that is going to come up. Do I think it would be beneficial to have things like that and ECMO and all of that? Like, heck yeah, I think it's super cool. And I wish we could run around and do some things like that. You know, and this guy who has like an isolated injury that, you know, you could potentially put Robo in and stop bleeding, I think it'd be great. Do I see that happening? Maybe in some population centers. I know there's some really progressive ones out there, like mobile ECMO units and things like that. So is it possible? Yes. Do I think it's going to be something that's common or routine and anytime in the future? No, I don't think so. It'd be cool. It's exciting.
Yep, I agree. Thanks.
All right, here we go. Case number 4. Getting a little short, so we'll kind of speed through this one. So this is going to be pretty classic, I think. So a 67-year-old female has some nausea, she's kind of sweaty, some indigestion, things of that nature, but no chest pain whatsoever. You get there, you get her vitals, and she's bradycardic and she's hypotensive. You get an EKG. That's an obvious one, right? So that's an inferior STEMI, and that's going to be like your classic atypical presentation, is like an old lady with indigestion or nausea and vomiting or belly pain or something like that. So this is an atypical presentation of a STEMI. Unfortunately, like STEMIs don't always look like this, and actually they more common than not look more like this. Much more subtle, much more fog of war, look over this, see some abnormalities, but you kind of move on, right? But this is an inferior STEMI as well. It's a lot harder to see, right? So this is going to be your more common issue, right? So this one, like, yeah, heck yeah, big STEMI, everybody's happy, we're calling the people, we're getting her to the right place. But this might be a little bit tougher to see, as might this. Same inferior STEMI, little bit tougher here, right? Same, difficult to see. This is actually, these are the same case. So these two guys here. So this one was, I believe, if I'm not mistaken, this is the case that this person was brought back, had come in for chest pain. This EKG was done, but trope came back undetectably low. The chest pain resolved. They sat in the emergency department for a little while. Chest pain never came back. They discharged them home. They went home, had similar symptoms, came back in the next day, had a troponin of 20,000. And if you can see right here, you've got kind of a normal Q wave, right? Like maybe a little bit of downward deflection too, but these ultimately look kind of okay versus this one. On the next one, you have these downward deflecting Q waves, right? And a little bit more pronounced ST segment. So this patient is starting to Q out. So he infarcted the day before, maybe was at like a critical stenosis level, but arguably this STEMI was missed, right? So this patient would have benefited from going to the cath lab and comes back with an obvious infarction and now with a little bit of ventricular dysfunction, a little bit of heart failure, leaving the hospital. So these things, all this point being, like these things can present atypically and they can present subtly, and they're not always the giant tombstones. They're not always the ones that jump out and are like, no question, no brain processing whatsoever. This is a STEMI. So what's happening when you have a STEMI, right? So these patients usually have a big coronary plaque that has been sitting in an artery for a while. So this isn't like, you throw a clot like a PE or something like that. This is usually an atherosclerotic plaque that's been sitting there, and over time, the top endothelial level inside of that artery has worn away. And so you get this rupture, so you get the loss of like the intimal layer of your artery, and all of a sudden all this fat, cholesterol, and all that kind of stuff is exposed. Well, it's like duct tape for platelets. And so the platelets start sticking to it immediately, and you develop the full-fledged occlusion. And so that's kind of how these acute STEMIs happen, right? So what are you at risk for in this situation? So you start to infarct a bunch of tissue, right? So you get dysfunction of the muscle itself, so you start to lose your full cardiac function, but you also disrupt those electrical pathways in the myocardium. So this can trigger your VTAC. This triggers your VFib arrest. That's why VFib arrest is such a big complication of STEMIs, is because you disrupt those pathways and you jump into VFib and die. You can also see third-degree heart blocks in these patients. That's why the rule that, a new left bundle was always a concern, because theoretically there was a disruption that caused the bundle branch block that was a result of an infarction, even though that's fallen more out of favor and more in favor of like a Scarbosa criteria. The presence of left bundle alone does not necessarily indicate an infarction. But the point of that being, you can really disrupt the electrical conduction of the heart and jump into a lethal rhythm. And then progressive injury. That's why this is a time-sensitive deal. Your myocardium can only hang on for so long. It's like any other muscle or tissue in the body. It can only go without oxygen for a while, or for a short amount of time, before you start to get irreversible damage. Then you get into heart failure, and people with heart failure die eventually. So even if you save these folks, if they've cooked for too long, they're going to wind up with lasting disability, and eventually succumb to their heart failure. So that is why these things are time dependent, because of the potential disruption of your electrical pathways, lethal arrhythmias, and then heart failure. So the common alternative presentations, right? So that's nausea and vomiting. It's somebody who's short of breath and sweaty. It's somebody who's passing out for some reason. It feels like maybe some chest tightness, epigastric pains, hurting like more and like you would find with like gastritis or pancreatitis. Start hurting in your back, your jaw, your shoulder. Being confused. These patients can have an MI, start to hypoperfuse, and then they can't really tell you what's going on with them. Isolated hypotension, isolated bradycardia, third-degree heart blocks, and things of that nature. All things that should prompt you to at least grab an EKG and take a look, right? The high-risk groups for people showing up in ways that you wouldn't expect are your women, are elderly patients, diabetics, and things of that nature. Dialysis patients who have reasons to have a whole bunch of other things going on. These are the ones who typically show up in your non-typical fashion, right? So a normal looking complaint, right, does not necessarily exclude your like acute coronary syndrome. So anytime that you have any kind of index of suspicion, just grab a 12 lead. So like I was saying earlier, this is kind of the process of how this happens, right? So you get this plaque that forms over years typically, and then you have a rupture of that intimal layer. All your platelets start to grab onto it, and you get a blood clot in that area, and now you stop that whole thing. You can see kind of that purple area of like damaged heart muscle. That's where you're going to start conducting that electrical activity poorly, and so that's where you can kind of jump into the VFib from that area. So recognition, right, is obviously getting an early 12 lead and recognizing your STEMI and your STEMI equivalents, which we have a slide coming up on. Giving your aspirin, giving nitro. It says cautiously, but really that's just more for a hypotensive patient. If you have an inferior STEMI that has a normal blood pressure, please don't be afraid to give them nitro. Getting your IV access, heparin if this is in your protocols, and getting them to a PCI center quickly. In the ER, we're doing a lot of the same things. We're giving antiplatelets, we're giving aspirin, we're giving heparin. If you're in a place where you're going to give lytics, if you're far away from like a STEMI center, you can't fly them or some reason, we consider those things as well. So nitroglycerin as you guys do, oxygen if hypoxic, and obviously getting them for PCI. Importantly here, I thought this was a great slide on your STEMI equivalents. Typically, other than scarbosa and maybe hyperacute, these don't necessarily mean the full-fledged, the big one, right? These are more of like critical stenosis EKGs. So like your De Winter and things of that nature can obviously indicate that you have a critical ischemia, like a 95% or greater stenosis, but not necessarily like your full-fledged 100% myocardial infarction. But these are things that you need to be conscious of so that you can at least communicate. If you're not transferring to a PCI center, these patients are going to need intervention at some point in the next like 24 hours, if not immediately. So if you see things like these big broad-based tall T waves and you don't suspect hyperkalemia, you need to be thinking about De Winter. If you have some subtle ST depressions that look a little worrisome in your anterior leads, like thinking about a posterior EKG in a patient that fits the right story, knowing your scarbosa criteria, that's a whole lecture in itself. So being familiar with what scarbosa looks like in a paced left bundle branch patient, very important to catch these things, right? Where you're gonna, not necessarily for your management, but just for kind of your information, these are the areas on an EKG that correlate to particular vessels, right? So your lateral leads out wide, like V4 through V6, that's going to be more of like your circumflex or maybe like a diagonal branch of your LAD. Your inferior over there in 2-3 and AVF, and then your anterior and septal, that's more of like your big Widowmaker LAD type infarction. Just kind of knowing those, not necessarily for your management, but can help you, at least be more communicative and, more cognizant of what may be going on there. So anyway, key takeaways: not all STEMIs present with chest pain. They may present very atypically, so having a high index of suspicion when things are weird. Your recognition of this and high index of suspicion can shorten the time to reperfusion, so limits their outcomes and improves their overall survivability of an MI. So essentially, your index of suspicion, your early EKGs save myocardium and save lives, right? Check. This one is sepsis. I think we're pretty much out of time, so I'll just kind of run through this as well. So this is going to be your old lady with, a UTI or a pneumonia or something of that nature. They're febrile, they're tachycardic, hypotensive, and things of that nature, right? So all of this to say, here's a little bit of pathophys. Similar to what we talked about earlier, right? This is a like cytokine inflammatory reaction that causes a lot of endothelial dysfunction. You get a bunch of leakage of fluids, so you get volume deplete, and then you wind up with your malperfusion, end organ damage, rising lactic acidosis, and kind of that same progression down that pathway, just like the trauma triad that you get into. You start to compensate less and less. So the biggest things we can focus on here is recognizing like our SIRS criteria, right? So if the patient's warm to the touch, they're tachycardic to tachypneic, you're not going to get a white count in the ambulance, but you can recognize the others. And if they meet 2 of 4, your suspicion for sepsis is quite high, right? Anybody can trigger sepsis, right? You can have the flu, you can have COVID and trigger sepsis. But if you're really concerned about sepsis, you want to start this volume resuscitation quickly, right? So just kind of a quick one here about how this is affecting things, right? So you get immune system dysfunction, you can get ARDS and things of that nature, AKI, liver injuries, bowel injuries, all of that kind of stuff just from your leaky fluids and malperfusion. Biggest things for you is to recognize, like, is this patient altered? Is this patient tachycardic? Are they warm to the touch? Are they hypotensive? From your standpoint, considering early vasopressors, fluid resuscitation in these folks and getting them back perfused as quick as you can is the way that you help out the most in this situation. There's some agencies that do give antibiotics. A lot of times the thought is you want your blood cultures and things of that nature before you start antibiotics. So if it's in your protocol, great. If not, you just focus on the resuscitation and we can handle the antibiotics in the ER. So your big takeaways here is like tacky anything is going to be your biggest early warning sign in these patients when they have signs and symptoms of an infectious process. Hypertension is dangerous and late, so you want to be on top of the ball. You don't want to ever deal with a hypertensive patient, but if you've got one, vigorous volume resuscitation as well as vasopressor support is going to be your friend here. Your recognition of this, getting them in so that they trigger all the signs and symptoms or all the bells and whistles in the ER. They get antibiotics earlier, which is associated with better outcomes. So your recognition, again, can improve the efficiency of the system and improve outcomes in the hospital, because a lot of these, just like an MI, there's a lot of time-sensitive outcome data that's out there. So your recognition can really benefit them in the long run. So all that to say, your recognition, your treatment can improve outcomes in the hospital, which is what we want to accomplish here. So all this to bring it home, right? Oxygenation before intubation. You want to resuscitate these folks before you stick a tube in someone, particularly who is volume deplete or has increased intrathoracic pressure. You want to make sure your patient is ready for that. ROSC is kind of the beginning of resuscitation for me. That's when it gets real. That's when the real care starts. Everything's algorithmic before that, but the real care starts after you get things done, and then you can make another big difference in their outcomes, right? Stop the bleeding as best you can and resuscitate them as best you can as well. If you've got blood, give it to them. If you got TXA, all those things, stick to your protocols. But your main thing is you want to try to get that bleeding stopped however possible. Your STEMI, so recognize your subtle and alternative presentations and making sure you're on top of those and getting them to appropriate care. And then sepsis, you're trying to identify the shock before it happens and get them volume resuscitated or support them with vasopressors prior to that kind of physiologic collapse, right? So all that to say, if you have questions, I know we're late. I know the food's probably here, so let's go get some of that. But if you got questions, if you want to talk about things that were on here, anything controversial, I probably mess something up. I mess things up every day, but hopefully the patient doesn't die because of it. So anyway, I think levo is your best catch-all. Levo is going to be, it's all encompassing, right? So it hits all of your alpha and beta receptors just as epi does at higher doses, but it has a little bit less on the chronotropic effect. So epi is going to kick your heart rate up first, and it's also going to help with your peripheral vasoconstriction and I guess systemic vascular resistance from that standpoint. Levo probably leans a little bit more towards increasing your SVR and then also increasing your inotropy as well. Levo, like I said, it's probably, I know it used to have a bad reputation. What do they call it? Levofed, leave them dead. But I mean, even in cardiogenic shock, all that, everybody's going to levo because of its kind of catch-all without drastic shift one way or the other, either towards alpha or beta. So I like levo and I use it pretty much everything. Bridge therapies, I'll give push dose epi. But my typical pathway in regards to sepsis is going to be levo, and then vaso, and then epi. That's kind of my 3 pressor progression. And then you start to get into all the crazy stuff. Right. So dopamine, I'll be honest with you, I have never once used dopamine on purpose. Just because, yeah, I've used dopamine in patients that are like, the only time I've ever used it in my career, which admittedly is not long, is there was a patient in the ICU whose family was in like Florida. They were on all 3 of the first, so they were max levo or over max levo, vaso, epi. They were on methylene blue. They were on angiotensin. They were on dopamine as well, just to keep basically their body alive at the will of the family to get there and see them. I know that is not the case, and I know that people carry that and use it routinely, and for some people, that's the pressor that they've used the most in their careers. I would say in regards to a patient like that is tachycardic and hypotensive, you don't want to run their heart rate up crazy high, but the risk of leaving them hypotensive to not mess with their heart rate is greater than the benefit of bringing up their blood pressure. I wouldn't have any way of really choosing dopamine over epi. I would go with epi in that situation, but that's because I don't use dopamine. I think it would be totally reasonable to use dopamine if that's something that you do routinely and you're very familiar with it. I wouldn't necessarily have a preference one way or the other just because of the heart rate, to be honest. And my lack of familiarity with dopamine is going to limit me on giving a good answer to that question.
Very good. Great lecture, Dr. Sullivan. We appreciate it. We also appreciated Dr. O'Brien's lecture earlier. I want to say thank you to Mountain Brook Fire for hosting us here today in their facilities. And as always, thanks to the Alabama Fire College for supporting Alabama EMS Challenge in these classes that we do. Once again, remind everybody to please fill out an attendance form. Even if you don't need the CEUs, we could sure use the data, and we enjoy reading the feedback that you send us on those forms. To get to the form, you can click the link in the Q&A section of the Teams meeting. There'll be a QR code up on the screen that'll be running here in just a minute. If none of that works, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the attendance form. The password for today's attendance form is seizure. And I believe our next class will not be until June the 10th in Clanton at the Chilton County EMA office there. So we look forward to seeing everybody then.